like I said, what I'm going to do is I'm going to use the software in front of you the way I set it up and the way I use it. Now, the settings that we have here are settings that we chose as a preference in our clinic. And we have suggested to Francesco that it may be possible, if you want, to ask for these settings in your clinic. Currently, when you receive an MS39, it doesn't have these settings. So for example, when you're looking at, you open a case, we have axial posterior refractive equivalent power, which is a total optical power through the cornea, corneal thickness, and axial anterior curvature. But we have it in our 6 maps, so we call this the London Vision Clinic 4 map. The London Vision Clinic 6 map is epithelium, tangential anterior, tangential posterior, anterior best fit sphere, posterior best fit sphere, and here we have stromal thickness map. Okay, so if you want the corneal thickness, you have to go to the 4 map. And now, we look at this map first, the 6 map, and also I want to point out that we use the American style scale, and we also have all of these overlays put on, all of them, because it gives us the ability to look in Cartesian coordinates or polar coordinates for locations of pathology. So in this case, it's a virgin eye, and we want to do refractive surgery on this eye, so we're screening for keratoconus, right? And so if you look at this map, you can say, well, okay, maybe something is not right. Well, let's look at the other eye, the right eye. Okay, here you're seeing inferior steepening on the tangential map, and you're seeing that the epithelium looks thinner in the region of the inferior steepening. Now, you can right mouse click here and normalize the color scale. So this exaggerates the scale from the top to the bottom of the map. And also, you can adjust the scale. So you can change the point at which the break point between green and blue, which can be used to emphasize things. So for example, if you don't adjust color scales, this could look, if you just glance at this doesn't look so abnormal. It's exactly the same data. But if you look at it like this, then it looks very scary. So we are always dynamically changing the color scale, always. You never use an absolute scale when you're looking at epithelial maps, ever. You always adjust the scale. And you want the highest sensitivity. You don't want the steps to be like this, because it looks normal. So you want a 1 micron step, even though the resolution of the device is sort of more like 3, but 1 micron step, and then you need to change the cutoff point until you emphasize the irregularity of the epithelium, okay? So once you've done this, let's look at the other eye, by the way. So this one doesn't look so abnormal, but when we normalize the scale and adjust it, do we see more? Maybe this inferior steepening is coincident here and there. So we now go to the keratoconus screening panel. Now, an extraordinary amount of work, of expert work has gone into this panel. On the right-hand side, you have parameters that were derived by a lot of you in the audience here. But this part of the panel was designed by me and my team in London, because we have been using this kind of collage for years now in terms of trying to put everything on one cockpit display so that we can see everything simultaneously and localize and compare irregularities between epithelium up here and, let's say, the back surface here. So the logic of this panel is like this. These three maps are the anterior surface, are from the anterior surface. These three maps are of the posterior surface. These two maps are the epithelium. This is, the top one is the epithelial thickness, and the bottom one is the pattern deviation map. So like on a glaucoma, you know, you're one standard deviation or two standard deviations from normal. Well, this is, you know, blue is two standard deviations thicker, and red is is thinner than normal, okay? And here we have a reverse, we look at this on a reversed scale. So our range is set to minus 2.5 microns. Many people say, why don't you put it the other way around so that when it's thinner, it's red? And the answer is, since 1991, when the first map of the epithelium was done, I decided to use opposite scales so that you don't confuse curvature with thickness when you're looking at maps. And also, you get used to it very quickly. So, again, we normalize the scale here and we adjust it so that we can see if it's, you know, we can emphasize any irregularities, and I don't think I can. That looks okay. Well, maybe here, you see, maybe here, okay? And then and now I'm looking on the horizontal lines. Oh, sorry, I didn't finish. Stromal thickness, which is the actual stromal thickness, and the pattern deviation, and corneal thickness and the pattern deviation. So you can see that the pattern deviation of this cornea is thinner than average inferiorly on the stroma. Okay, so already you're making notes in your mind. Now here we have the anterior tangential Gaussian anterior, which is a Francesco idea, which is a much better representation of local curvature than tangential maps. Tangential maps are better than axial maps, but the Gaussian is really a very averaged, localized curvature. So if you're looking for localized irregularities, the Gaussian map is the best we have. And then down here is the old map that was on the keratoconus screening of the PEEF3 software. So it's basically a pattern deviation from the average wavefront of the back surface. Am I correct? Am I correct? Yeah. Yes, okay. Okay. So when I look at this, really, I've already looked at the 6 maps. So I start here, and then I go directly to the keratoconus screening. And the first thing I look at is these 2 maps down here. Now I'm seeing anterior and posterior elevation, and they're pretty much in the same place. It's looking a little bit suspicious, especially the posterior. Now the software is supposed to select the axis of the steepest point. Right now it didn't, so I'm just going to move it one scan further. And you see this map is the anamorphic display. And you know, when you look at these maps, there's not much information that you can get from it. But the idea that we had, and we started doing this with ultrasound in 1991, where we would put the front surface, we would make the front surface flat. And then all of the other surfaces now, the relative curvature is much more obvious. So, for example, in this cornea, if I look at this axis down here, you see, I can see the back surface is a little bit elevated here, yeah? Which you cannot see if you're looking at a section. You can't. So this is, if you like, a z-axis stretch plus a normalization of the second, third, fourth, and fifth surfaces to the anterior surface from a visual standpoint. Okay, so this map down here is helpful because when you're looking at, you can actually use the mouse to rotate and see how this back surface distorts. See, here you're starting to see distortion, and there. It's visible. It's visible. It's a visible cone. Yeah? Also, if you move the mouse along here, the cursor, watch the cursor on the back surface. The cursor moves and tells you where you are. So I'm pointing at the cone here, and you can see it pointing down there, yeah? So in this case, we have posterior surface elevation, which is, and I'm going to put the cursor at the apex, and now I'm going to look at the epithelium. And you can see that the cursor shows that there is thinner epithelium over the posterior surface elevation. And as you know, we published our first paper describing this concept, I think in 2009. And this is really one of the most powerful tools for excluding keratoconus, okay? And I'm going to show you a few cases like this. So this is an example of an obvious keratoconus, because obviously the other eye is, like I showed you, the other eye has much more obvious epithelial thinning over the cone. It's completely obvious, and when you look at this pattern, you look at the anamorphic display, I mean, right? It's obvious. So, okay, let's look at case number 2. I'm supposed to look at, so what we've done is we've imported these from our clinic in London here, just so that you can see this is what I would be doing. Now, this case is interesting because if we look at the central, there are central cones, and you have to be very careful about central cones because they can be easily missed. Now, in this case, if we go to the keratoconus display, we see that normalizing the posterior, I'm sorry, I didn't mean to do that. 1 second here. I'll have to come out and come back in. Normalizing the anterior surface. There's a little bit of asymmetry, and the difference between the center and the periphery is quite marked. Also, it's coming out on the wavefront analysis of the anterior surface, and it's coming out a little bit on the posterior surface. So if we go to the axis of the steepest part, and now we look at the epithelium, what can we say? Well, we can say that although the fellow eye is classified as borderline by statistical methods, here we are, fellow eye, borderline check parameters. Ectasia index of the posterior surface is flagged. So here we are, posterior elevation versus normality. This looks suspicious, but this cannot be keratoconus. It cannot be keratoconus. You cannot have this degree of focal elevation of the posterior surface without some kind of matching degree of epithelial thinning in that region. It's just not possible, because keratoconus is not a disease where the posterior surface changes first and then the anterior. That is old school. That is before people were thinking about the epithelium. That is because first you saw the back surface elevation on the orb scan in 1996, and you didn't see changes on the front surface because the epithelium was compensating for the front surface changes. It's the compensation which we look at now, and that compensation is a highly sensitive way of classifying whether a back surface is really abnormal or just elevated abnormally. Some people are fat, some people are thin, some people are tall, some people are fat. There's a normal variation in the deviation of the pattern. If it's keratoconus, the front and back surfaces move together, okay? And therefore you will have a change on the front surface in the epithelium. And in this case, I would do LASIK with a Hansatome. I don't care. With a Moria, which cut really thick flaps. So for me, this is the kind of case where epithelium becomes, if you don't mind me saying, a money generator. Because when you pay whatever you have to pay for this extraordinary device, you get the money back very quickly, because you are now ruling cases into surgery that you wouldn't have been able to do. And you don't have to do a lot of mathematics to calculate the price of one LASIK patient, marketing costs to get them in, that's high, and then you don't do the surgery. So add that to the fee of your surgery and the profit. This thing gets paid off rather quickly. So we have 5 of these devices in our clinic, yeah, for 2 surgeons, yeah? So it's because every patient needs everything done, and every patient needs this map at every visit, because we use the epithelium to monitor if ectasia will occur, not the curvature. By the time you see a curvature change, it's too late, right? You want the epithelial change over time, because if you cross-link someone when only the epithelium has changed, they're never going to know they had ectasia, okay? Right, case number 3. I have to look at my scale here. Okay, case number 3. So we always go to the 6 map first, and we're seeing a very, centrally elevated central cone. Again, they're always worrying when you have localized central cones. Those are the ones that scare me, because those are the ones that I'm well, is it or isn't it? And of course, you go to the keratoconus panel. I always check my colleagues' work over here, and my colleagues are telling me, no LASIK. And I'm going to say, well, hold your horses here. Let me take a look. Because the axis, if we look at the axis here, there really isn't, I don't really see an elevation here visible. And when I look at the epithelial map normalized, and I adjust the scale, and I put my cursor on the cone, and I look at the location on the epithelium, I don't see a lock and key fit between the epithelium and the back surface elevation. And that is, for us, the most powerful negative sign, okay? Because that includes patients into surgery. So this is a patient, well, let's look at the other eye. Same thing again, back surface is very, very strange. But epithelial map, as you can see, no, there's no way. There is no donut of epithelium. There's no focal thinning with thickening around it, as we described it in our 2009 paper. And so therefore, this, although it is classified as keratoconus by shape factors, when you look at the concordance between epithelium and back surface changes, you can confidently exclude keratoconus. And you can do LASIK with a Moria. Actually, you can do it with a flap maker, because that machine made 250 micron flaps, if you remember, that. Okay. Yeah. The enantiomorphism is when you look at the right and left eyes and then a subtraction between the two. So it shows asymmetry between the two. And the bilateral summary, we always set the posterior versus normality against the epithelium, because that's the comparison that you always want to look at, okay? So this is, again, a case where we do the mapping, most people would do a pentacam and they would have to cancel the case. And we look at back surface and epithelium and we say, come this way, okay? Right. This is an interesting case because, let me just see my scale. Okay, so I'm looking at the right eye. There it is. Now, oops, one second. Yeah, okay. So this is an interesting case. So here's our 6 map. We have a very steep central tangential curvature and back surface, front and back, right? And the epithelium, it doesn't look good, does it? It doesn't look good. You agree with me, okay? So now we're going to go to our keratoconus display, and we're starting to get a little concerned here, okay? You know, we place the cursor, it doesn't look too bad, but this is scary when you have concordance on the front and back surface, and the epithelium, you know, it doesn't look quite right. There looks like there could be a cone coincident, right? Do you see that? There's something, and the keratoconus is classified here, right? Okay? But, oh, sorry. Okay, we're going to leave that. So let's move on to, so this is kind of the keratoconus, you know, windy road that we're going through. Obviously, it would be nice if we had some kind of artificial intelligence assisted way of looking at what I'm looking at right now. That could be machine learned, and then we could have a parameter around that, but we're not there yet. Now I want to show you a couple of other things which I worked with Francesco to program here. And this one is, yeah, so it's called the Reinstein cap display. Now, you know, with ultrasound, we've been mapping different layers for 25, 30 years now. But the OCT gives us a very quick, very easy way of getting an average idea of where the cap is in SMILE when we want to plan a flap on top. And so this is displaying all of the not the quadrants, but you know, all of the different, the central, superior, inferior, infratemporal. And what you do is you go through and you only have to click in one place on each map. I'm going to do this, you know, relatively quickly here. And around there, and here, and here, there, and there. Okay? So what this does is that shows me the cap. And if I just show you, I show you this case. This was a minus 225, which ended up on target. But if I had to do an enhancement, you see, you cannot measure the cap and know what the cap was at the time of the surgery because the epithelium has changed. Many publications, they try and do the flap thickness measurements post-op to see if they were accurate, but the epithelium changed, so you can't do that. You can only do what happened at the time if you get the stromal component of the flap post-op and add the pre-op epithelium to it. Then you know what the flap or cap was. But you see, this is the way that we program flaps over caps. We need to know what the minimum thickness is or the maximum, so that we can make sure that we program a flap on top and that it's not going to cross into the interface, okay? So if we go now to another example where we are going to plan a flap, a new flap, in a case that already had a flap. So this is a patient of mine who I did surgery on here. So, oh, I selected the wrong one, that's right. So this is somebody who, hang on, is this right? Yeah. So this is someone who in 2009, I did a hyperopic correction in this eye, and the patient was exactly on target at 1 year, and he came back at 13 years post-op, a little bit hyperopic again. And I know most people take clear lenses out, but everyone here knows my view on clear lens exchange. And so here's the map. Now, of course, not often with OCT can you see the interface, but you can sometimes, and in this case we could. So the primary flap programming was a 100 micron flap, okay, in an 8mm diameter. So it's somewhere in there, right? It's somewhere in there. So I'm going to go to the software now, and we're going to look at the display. Now, you can see that there is this hypo-reflective zone. And that is actually where you can make this window larger or smaller by holding the Shift key. And so I'm going to kind of map it around here. There. Obviously, this is, you know, look, you move a few microns. This is not exact, it's rough. But it's good to have a rough guide quickly. If I had to do an insight, there you go, there's the map. And what I do then is I know how to program the next one, because the thickest point of this flap is 134. The thinnest, therefore, of a new flap would be 18 microns less than a programmed 155, because the 18 microns is 4 standard deviations with the Visumax. So the thickest is 134. To make sure I don't cross the old flap, I go more than 18 microns below, and I make it wider. So this is called a wider, deeper flap. And we program, therefore, 155 at 9mm, and we can, therefore, safely create a second flap and avoid ingrowth in a flap that was made 13 years ago. I don't want to necessarily lift that flap. I'm just giving you an example. Finally, very quickly, many of you do smile here, but refractive surgery should be centered on the visual axis, not the center of the pupil. And for years, we've been using a rings map inverted, and you know, my technicians have to make these maps with vectors, and we have a standard protocol where this image goes in front of us. It's inverted, so when I'm looking in the microscope and then I look up, I can compare my centration of the smile with the centration of the vertex of the placido. And I'm just showing you here my friends in Peru who are following the exact standard operating procedure. And I asked Francesco if he would be able to program this, and he did. So when I do suction, and then I look at this, and then I look at the Hirschberg reflex that I had pre-op, and obviously I have my docking stages of smile, and I have this image in front of me, and I can compare them. And so now we have, in one go, we can immediately have this display where we have the X and Y deviation from the center of the pupil to the vertex, and we have this visual target display that shows us how the centration will be. And this is a stop photography of where I centered the left eye and where I centered the right eye, and you can see that I'm exactly where I intended to be. Okay? So this is, if you're doing refractive surgery, if you have this display in front of you in the OR, you know, your machine might think that it grabs the vertex or the correct location, but you can verify it visually like this. It's like a double check, okay? So these are just a few little things that I got involved in, and I thought it would be nice if I shared it with you on the software so you can see a more dynamic way of how this software, which is phenomenal. And the last thing I'm going to say is that, you know, it's interesting how this device, I think I saw a prototype probably in 2015, there, of course, all the other OCT companies are starting to try to do topography and do the same thing now, obviously. But there's one advantage about this machine for me, which is that this company has been in topography for 30 years. And so their knowledge base and their analytical capabilities in the software are so far developed that if you're a company starting to write topography software, you're starting from scratch. And so this machine for me is really the most powerful device that I have in my clinic. And like I said, I have 5, 4 in my testing rooms and 1 on my desk. So I have a slit lamp and my own MS39, which is my slit lamp of the 21st century, because if I want to look at cross-sectional imaging, I can do it immediately. If I want to look at difference maps, I can do it immediately. I don't have to send the patient out and bring them back in. So congratulations to CSO on this device and Francesco and his team.